Attorney Monday is that the petitioner was employed as a painter. There's not the typical kind of language that you see in some of the other cases. This was heavy occupation or this was a light occupation. There's just a blanket statement that the petitioner was a painter in this case. 58 years old at the time of the injury, although there's no real discussion about which way that she cut, as there was in the previous case that we talked about, a younger individual having to live with it for longer, an older individual, maybe in this case, having to live with it for fewer years. Earning capacity, it was important to the arbitrator to mention, even though there was no linkage made in terms of the decision, that this petition was terminated while awaiting medical treatment. Okay? So, and if you go back to the Frederick Williams case, that very first case that was decided, the fact that the petitioner has not gone back to their job seems to make a difference in this future earning capacity factor in some way or another. Evidence of disability, in this case, you can see that once again, the arbitrator is saying that it seems like the petitioner's symptoms that he's complaining of are consistent with what the treating medical records show, despite the fact that he was released and returned to work full duty. Okay? So again, a really kind of nice analysis, which is why I included in the written materials about how to analyze each factor of Section 3.1. Any questions or comments about Stormy Monday? Stormy Thursday? All right. You can look at these other cases. Some are modified up, some are modified down, and so depending on your circumstances, what you're arguing for or about with the commission, you should look at those cases. Kevin Klein is just another case where there was no AMA impairment. So let's take a quick look at December 2014 cases. A bunch of cases where the AMA guides analysis is used by both the arbitrator and the commission. At least one case where there was no AMA impairment rating. Again, that needs to be a state of Illinois case. I don't know whether that's a coincidence or not, but at least in that case there was no AMA impairment rating. So the two cases that I wanted to focus on here are this Saprinski case. Clearly it looks like the date of injury in this case is no problem because it's after September 1, 2011. Mr. Saprinski was a 47-year-old extruder sidewall operator for Continental Tire, which I understand is some type of machine operator. They make tires, and he's working on a machine that extrudes sidewalls. So he's had a TFCC tear, and ultimately he has surgery and is released to return to work full duty. The reason why I wanted to point out this case to you is that, as far as I can tell, this case is one of the first cases, if not the only case, to rely on the different method of rating an AMA impairment rating, right? I hope by now we're all familiar with the general way of doing an AMA impairment rating is called DBI, right? Diagnosis-based impairment. So, you go to your book, right? And you find in your book the chart that describes your diagnosis, right? And then when you find your diagnosis, you read over and you see what the numbers are for that particular diagnosis, right? So that's called a DBI impairment rating, diagnosis-based impairment rating. The diagnosis is the key factor. So this book calls the key factor, right? If you determine that, you know what box you're in, you know what row you're on, and you can't ever get out of that box in that row. You're stuck in that box, right? There's an alternative way of doing an AMA impairment rating, especially involving the upper extremity, which the hand is considered to be in the AMA guides, right? It's part of the upper extremity, but it's considered to be upper extremity. And if you look at all of the diagnoses in the upper extremity section of the AMA guides, there's going to be a little asterisk, okay? And that asterisk, when you read at the bottom of the chart, what that asterisk tells you is that if motion loss is present, this impairment may alternatively be assessed using section 15.7, range of motion impairment, okay? ROM impairment, range of motion impairment. It's a different way of doing the rating from this EDI. As far as I can tell here, Supremacy is the first case that I've seen reported that uses that ROM way of doing the analysis. Is that important? I think it's really important. And I know a lot of you are saying, come on, Dave, that's really, that type of triviality is important? It's extremely important because in order to adequately and to appropriately apply the rule of liberality, right? We all know about the rule of liberality in this book. If there are two different ways of doing an impairment rating, you've got to pick the one that comes up with the better result, with the higher result. That's what the rater is instructed to do by this book. So in this case, Dr. Howard apparently did that. Apparently he said, look, even though the preferred way is EDI, okay, the diagnosis-based one, he said, I think apparently, I think in order to comply with that rule of liberality, I think the higher result is from using this range of motion analysis. So I think it's a really important thing. On the other hand, and I don't pretend to be a better AMA impairment grader than Dr. Howard, I wouldn't do that at all. But if, in fact, he thought that 3% was a better impairment rating, if the diagnosis here was actually a TFCC tear, when I look at page 396 of the book, and I look at table 15.3, which is a diagnosis-based impairment, I see diagnosis-based impairment for TFCC tear, okay? And if that TFCC tear is documented TFCC injury, plus or minus surgery with residual findings, and I think Mr. Saprinsky certainly had surgery, and I think he arguably at least had residual findings, then if you look at the range of value for that particular box, the lowest value is a 6, and the highest value is a 10. Okay? So, it's important to keep in mind the asterisks, right? You've got to pick the one with the higher rate. That's what the book instructs a rater to do. So, a really interesting case in my opinion because of that range of motion analysis, maybe not so interesting to the rest. Yes?
So based on what you just said, you don't have discretion as the examiner to pick one or the other. You have to pick the one that is the higher rating.
Okay. So I'm not going to editorialize. I'm going to read the sentences from the book, okay? And you draw your own conclusions, okay? If motion loss is present, this impairment may alternatively be assessed using section 15.7, range of motion impairment. And some people might say, yeah, but it says may alternatively be assessed. But that has to be read, okay, that rule has to be read in conjunction with the fundamental rules of the guidance, right? And one of the fundamental rules of the guidance, and we know that because it's in the first two paragraphs where all the fundamental rules are laid out. One of the fundamental rules of the guidance is on page 20 of the guidance, table 2.1, and it's rule 12. And this is what, and it's titled Fundamental Principles of the Guidance, so I'm really not making that up. And rule number 12 says, if the guidance provides more than one method to rate a particular interpreter condition, the method producing a higher rating must be used. Okay? So, here's our actually AMA impairment rating expert, Dr. Robert Renee, who is also a lawyer and a WICLA member, who is certified to do ANA impairment ratings, is going to just tell me that I'm wrong, right? Okay, all right, so.
And as for that alternative, you'll find it in other portions as well, as an example, risks, because I did one of this. But I have a question. Did Dr. Howard actually do the DEI rating as well?
I couldn't tell whether he had actually done the DEI rating or whether this is just, or if this is just his conclusion after he did the DEI rating. I can tell you that if you have maybe I'm giving away all our secrets, but the fact of the matter is that as a response lawyer, you have an ANA impairment rater who says, look, I did the two alternative ratings, but this one's the higher one. Tell him I need to see your work. Show me your work, right? You're charging me $1,500 for one of these things. You could at least show me your work, right? Because otherwise, a petitioner's lawyer like me is going to cross-examine the lead out of him over why he didn't do it that way, okay? And apparently it makes a difference. Yes?
One more thing, and I don't mean to be difficult. But you said, and I don't know where it says it in the guide, maybe you know, that this is the alternative method, especially for the upper extremity.
Well, it's
Or
where
the upper extremity?
it's where, no, it's not only, but it's where the asterisk appears. Okay, so where you get to the box and you see the asterisk, if you go down to where the asterisk is explained at the bottom of the chart, that's what it says. So it's in many, if not all, of the upper extremity impairment rating. It might even be in all of them, okay? And if you think about it, you might think that that makes sense, right? Because range of motion is really important with the upper extremity, right? So, but it's where the asterisk appears, and you'll see it. I mean, it's very small, but you'll see it. It's an asterisk, and then you go down, and that's what the asterisk tells you to do. Okay. Anything else? Okay. Carl Jones is a case. It's actually my office's case, so I wish it had turned out a little better, but it didn't. And but there's a nice analysis in this case about how the 5 factors of Section 8.1B were used. In fact, the commission modified it up a little bit from what the arbitrator had previously awarded, and the commission thought that things like the MRI and the last visit with the treating doctor and the follow-up after being released by the treating doctor were important things that allowed the commission to modify this decision. So, any questions about the December cases? All right, let's take a quick look at the January cases then, and we'll be done. So, if you look at this transient case again, another state of Illinois case, and I don't mean to be, mention the state all the time, but here's another state of Illinois case where there was no ANA impairment rating. So, despite the fact that there was no ANA impairment rating, the commission modified this decision down because the commission found the award to be excessive. Okay, and so here's a case where Section 8.1B applies. There was no ANA impairment rating, and yet the commission modified the decision. So Ramon Rodriguez is another one of the January cases. I'll talk a little bit more in detail about that one. Keith Littlejohn is an important case that we need to talk about, and I'll talk a little bit more about that in detail. That's the one that I give you in the written materials. I think it's that important. Michael Griffin is an interesting case because in this case there was no ANA impairment rating, but the arbitrator inferred that when the IME said that there was no permanent disability, that was pretty much the same thing as saying that there was a zero impairment rate. But the commission didn't necessarily agree with that, and modified the decision up to 2.5% loss of use of the person's goal from 0% loss of use of the person's goal. So again, the definition, anything was a modification. Again, Daryl Earhart, another case, pretty recent case, a case within the last 60 or 75 days, where there's no A&A impairment rating, and yet the commission is affirming an award. So let's take a real, a little bit closer look at this Ramon Rodriguez versus Earhart case. In this particular case, Dr. Lieber assessed an impairment rating of 2% functional impairment of the right lower extremity. I'm not sure where that term of art comes from, because it certainly doesn't come from this book. So I think perhaps what Dr. Lieber meant to say was a 2% lower extremity impairment or something like that. The arbitrator only placed some weight on this particular factor, because as you can see, the arbitrator in this particular case concluded that the impairment assessment is woefully lacking. Okay? And it's pretty strong after woefully. Okay? So take a look at this case to see if maybe perhaps you have some A&A impairment ratings that are woefully lacking. It's interesting to me because it's maybe the first and only case that I've seen anyway, and somebody tell me if I'm wrong, where if you go back to section 8.1b, paragraph A of that section talks about how the impairment rating should include these things, like studies of motion, studies of strength, studies of atrophy, okay? And apparently Dr. Lieber didn't do that, and the arbitrator put only some weight on his A&A impairment rating because of that. So take a look at section 8.1BA, which tells you what an impairment rating should include, because if it doesn't include that, maybe your impairment rating is woefully lacking too, okay? This particular petitioner was a route salesman, so that's given some weight, I suppose, because it's heavier than a light duty type of work. The petitioner was 33 years old, although the arbitrator in this particular case didn't necessarily assign that any particular weight whatsoever. No evidence of impact on future earning capacity, so again, no weight attributed to that. The diagnosis, in this case, it was a torn medial meniscus, a scope knee, working without restrictions. The petitioner has some complaints, so that factor is given some weight. And in that particular type of case, despite the 2% impairment rating, there was an award of 20% loss of use of the leg, which was determined by the commission. All right, any questions about that one? Okay, Little John is the case that I wanted to spend a little bit more time on. Is Charlie here? Charlie is here? Okay, okay. I didn't mean to single you out, but I'm going to anyway. So if this was Charlie's case, so he'd be happy to answer any questions that you have about this case. But I want to point this case out to you because it once again highlights that kind of rule of liberality that the book talks about. This idea that if there's a diagnosis that gives you a higher impairment rating than the one that is being used, all right, the doctor should use, the rater, I should say, should use that higher rate, should use that more serious diagnosis. So in this particular case, Dr. Arabindi rated it as a 3% loss of the upper extremity But Charlie was able to convince the arbitrator of, and I don't think it really took much convincing because it comes right out of the book, is that there was a different diagnosis that could have been used to yield a higher rating, okay? And so when you're dealing with a shoulder case, you have to be aware of this, all right? Because if you're dealing with things like a diagnosis of impingement syndrome, or a diagnosis of rotator cuff injury, or a diagnosis of rotator cuff tear, you've got to realize that if there is an acromion, I'm just going to say AC joint, because I'm not going to be able to spit it out, okay? So if there's an AC joint injury or disease, it puts it into a higher rating, okay? And this is, as far as I can tell, the first case, reported case, that actually does that. It says Dr. Arabindi used the wrong diagnosis. He used the rotator cuff diagnosis to come up with the 3%, when if you are into the AC joint injury or disease, and that's on page 403 diagnosis, okay, if you have a status post viscoelastic resection or AC separation type injury, okay, or, so if you have a resection or a separation, the range of value for that is from 8 to 12, okay? So 3 doesn't work when the range of value is 8 to 12. By the way, there's an asterisk in that box too, okay? So not only perhaps should Dr. Arabindi have done a higher rating, he should also have done perhaps the range of motion analysis to comply with that particular provision too. So this is a really important case for shoulder injuries, okay? Because it shows you that if there's an AC injury, distal clavicle resection, it puts it into that higher category of 8 to 12 as opposed to the you know, if you're looking at a rotator cuff injury, with or without surgery, the range is 1 to 5, okay, as compared to 8 to 12, all right? Okay, so it's an important distinction to make. Charlie did an excellent job of analyzing the factors here too. Because the occupation is heavy work, PPD is larger than an individual who performs lighter work. 61, an older individual, less likely to have that PPD, you know, as long as a younger individual. Future loss, no evidence of that, so that doesn't come into play. But look at the factor involving disability. The procedures that were involved with this case were really important to the arbitrator in determining what the disability was. Even though the petitioner didn't release to return to work fully, the functional capacity evaluation had indicated that having demand level. There's this great sentence that you keep seeing repeated throughout these decisions, that PPD is not simply a calculation like an AMA term rating is, that it's an evaluation instead. So in this particular case, the award from the arbitrator was 15% loss of use of the whole person, which is the equivalent of a 29.64% loss of use of the arm. Based on the 8.1B analysis, the commission actually modified this one up to 17% loss of use of the whole person, which is a 33.6% loss of the arm. And the commission relied on the arbitrator's analysis of section 8.1B, but believed that additional PPE was required. I love that word, required in modified up. So, and that was based on the fact that there were multiple tears and multiple procedures in this case. Anything I missed, Charlie, you want to add?